Okay, we're set. Great.
Oh, because you know what's going on.
So we're at the Amber Hospice. My name is Leah. I'm the allied manager. So I manage our chaplains, our social workers, our bereavement coordinator, and our volunteer coordinator.
And I'm Valerie. I'm one of the on-call nurses with Amber Care.
So today, what we kind of wanted to talk about are end-of-life medications. As you know, sometimes these medications can be a little bit scary at times, right? And so that's where we wanted to provide some education on what these medications do that you might be hearing about. So today, we'll talk about first some of the symptoms that you'll see at the end of life that might require some medication interventions. We'll talk about what we provide and what we call a comfort pack. It's a group of medications that we provide every patient in their homes, just in case. Not everybody needs them. We'll talk about myths regarding some of the medications that we might have heard before. And finally, oxygen that is included on a medication list sometimes at the end of life, and what is pertinent as far as oxygen. So, the reason why I have a nurse here is because we are handling medications. I can talk about some of the symptoms that you see, but really she's going to be your expert here on these 5 medications here. But a lot of the things that we see at the end of life are some respiratory symptoms, some noisy breathing. Sometimes I call it the death rattle.
That's common, or it's like a gurgle. It sounds like you're blowing through a straw into water. And in the end, and it doesn't happen to everyone, it might be very subtle, but it's just the lungs are producing those extra secretions. And we do a lot of education with that particular symptom because it can be very scary. It's very scary to hear for the families and other loved ones. Subtle, and it can get progressively louder. So it can be scary. And we do have a medication that we give that helps dry up the lungs as much as possible. And it is called glycopyrrolate.
Called what?
Glycopyrrolate.
We'll go into that specifically. Obviously, pain is a huge symptom. That's one of our mottos is no one is to die alone, afraid, or in pain. So that will be one of the medications that we'll do. Agitation and restlessness. Sometimes you can see, people who are can't stay still in bed. It's just not comfortable to look at. There's a thing called terminal agitation, which you've spoken to. Explain a little bit more about that.
Yeah, and it can be, again, it's just a wide range for people. It can be very subtle, where they're just kind of grabbing at nothing in the air, or they're pulling at their clothes, or it can be something where we really need to help calm them as much as possible because they're trying to get out of bed. It's a little bit more so like where we're worried about their safety.
Another symptom at the end of life are dyspnea or changes in breathing. It can be alarming at first to see that there'll be periods of, regular breathing, and then periods where you feel like you're not hearing anything or seeing anything, or rapid breathing. There is urinary incontinence, or retention or decreased output. So you may not be seeing any, urine at all, any output at all. Fever is a very common symptom too at the end of life, which with somebody like you or me, a fever is something that we would right away, want medication for or something like that. But it's different at the end of life.
It's different because it's more so a loss of circulation in the extremities, and that blood just shunts to protect the vital organs, brain, and that's why you get that heat, that fever.
So does that mean it doesn't need to be treated?
I'm sorry?
Does that mean it does not need to be treated?
It's more in a comfort way. So, you would maybe take off blankets, put on cool wash rags, that sort of thing.
Okay.
And again, it can be very subtle, or there have been times where I have patients where you can just hover your hand and you can feel it. So just comfort, treating it as comfort.
Okay.
And another symptom, we see it too, nausea and vomiting. Another symptom. So are going to be determined by the doctor. We will always start out with low dosages. For example, with morphine, we start out at
0.25.
very small syringe dose. With something called lorazepam, we start out with
0.5.
0.5.
So just one tablet is what we provide the 0.5.
It was also very common to mix some of these medications to provide them together because they're more effective when provided together. So these are the 5 medications that we have in our comfort pack. We have morphine concentrate, so it's usually in a little liquid bottle. We have lorazepam, glycopyrrolate, ondansetron, and senna. And this is where I will kind of let Yellow switch and take the show because she will go into detail with each one of these medications, what they do, what are some symptoms that a patient would need something like this, and what might be some side effects. So,
Okay, so with the morphine, that is one that we tend to start off with even before end of life. It's just depending on what's going on. Pain, and we can even use it with like restlessness in combination with the other one, and shortness of breath. So end of life, we are going to see that increased pain, increased agitation, and like Leah said, you're going to start off low and slow, and then we go from there. Maybe at first they only need it every 4 hours, and then we have to move it up to 2 hours or 1 hour, or maybe we just have to go up on the dose. Very few times do we see a side effect such as nausea, vomiting with it. It's rare, and we'll address that if it does happen. The shortness of breath. So it might, some people think that maybe it's going to stop their breathing. It does slow their breathing down so that they're comfortable, but it's just basically relaxing their diaphragm so that they can breathe a little easier. It is going to cause sleepiness. Now, theoretically, if they're in end of life, they're probably already a little bit more lethargic. Now, with lorazepam. Okay, so lorazepam is the other one that we use alongside with morphine if they're having end-stage agitation or anxiety. And that is going to have similar side effects, the drowsiness, the sleepiness, and sometimes we hear, well, we don't want them to be so lethargic, but we have to think about the safety of the patient. So if they're very agitated, they're trying to get out of bed, then this is a good medication to start with. And typically it's every 4 hours. There are times that we have to move it up to every 2, or we just go up to 1 milligram, the 2 tablets. And again, that with the morphine works really good. Because it comes in tablets, it confuses people. How am I supposed to give this if they're in a comatose state? And that's when we teach how to crush that medication, mixing it with the morphine and drawing it back up. And that's how we administer it. Okay, so this is the one I was talking about for the secretions, the glycopyrrolate. So we're trying to at least dry up a little bit of those secretions. It may help, it may not. Very different for everyone, but we try to at least administer it for comfort. Same thing, you're going to crush it. You can administer it with a little bit of water using that syringe, or whenever you give the other 2 meds. Now, it could dry up like the mouth and the eyes, and in that case, comfort, you're going to swab their mouth with swabs, that sort of thing. But it can be very helpful for those secretions that are scary to you.
do those secretions that we hear, do they hurt the patients?
They do not hurt the patients. And I always point out that no matter how much education we give, when we come to that point, you're going to be scared. Because it does sound like they're drowning. It's scary. And it'll sometimes just sit right here. It sounds like it's in their chest or their throat. And there are times where it does come up. And just positioning the patient to where you can maybe put a towel and swab in their mouth that is sufficient, but if it's just sitting here because those secretions are kind of walking back and forth in small parts of the lungs, that's why it sounds scary, and that's okay. There is no deep suction, nothing like that. So it doesn't hurt the patient, it's more bothersome to hear for the rest of us.
So it's really up to the family's decision, you know.
Okay, so the Zofran is going to control nausea vomiting. I don't really see this at end of life, like where they actually do need it. It does happen maybe prior to them slipping more into that comatose state, but if they are experiencing that nausea vomiting, which can happen, or it can even be a side effect of the morphine and the lorazepam, then we do administer the Zofran. It's very helpful in just calming things down. But it doesn't necessarily mean that, say, like the morphine and the lorazepam are always going to cause that issue. It's more so an end of life thing that happens. Senna is for constipation, and that does happen during end of life. However, keep in mind, is the patient alert enough to take that medication? Because it's not a medication you can crush. Have they been eating? Is their appetite okay? Then you would administer this. Otherwise, we do expect their valves to slow down. And of course, if they're lethargic, this is something you don't want to give.
And like you said, morphine might be something you started before that stage that we're in, and that can cause constipation and symptoms. You would compare those two together.
So, back to the Senna, how do you administer it then? I missed that.
So the only thing about Senna is that it can't be crushed because it is coated. And so if that patient is still, like Leah said, taking morphine or lorazepam, which does cause constipation, and they're very much awake and they're able to swallow, then we administer it. So it's a medication that's available over the counter that we provide. And then once they're more in the lethargic phase, they're not eating, then we stop. But it is something that is common to use when you're using narcotics.
So they can still get plugged up, right?
Correct.
So it's just
Yeah, towards the end, we expect those valves to slow down. This is just prior to those things happening so that they're as comfortable as possible.
You could give us a suppository.
We don't want to be that invasive at end of life. So this is the same thing with the suppository. We would do those things, again, if the patient is eating, they're a bit more alert.
Yeah, okay, good. Okay, thank you.
One of the reasons why we wanted to present on medications at end of life is because there's a lot of myths floating around out there, especially about morphine, the N word. It kind of scares people a lot. So one of the myths that we often hear is that people believe that morphine will cause patients to become minimally responsive or in a comatose state. Not very true. It can cause sleepiness, as we discussed before. But really, the goal of hospice is to provide comfort and to provide a pain-free death process. So we do not ever want somebody to be in this perpetually sleepy state, or as some people call it, it's about comfort.
I had mentioned earlier, it more so just slows down the breathing when they're having that rapid breathing, or of course if they're in a lot of pain, then we want to be administering morphine, but it doesn't mean it's going to stop their breathing, and I think that's what's scary, is people associate it with an overdose type thing.
Another big myth that we hear a lot is that people might believe that morphine will accelerate death, or those convenient things that it would have the patient stop breathing. That will be the thing that will essentially kill the patient. Not true. Not true at all. There is absolutely no evidence that morphine will speed up a death process for anyone.
that's again where we have to go in and we have to make sure that, we explain those things to the families as well as to the patient. This is for comfort. We do monitor very closely. I know I tell my families to please write it down, because if they do exactly what we guide them to do and they call in and they say, hey, we did what the nurse said to do, it's not working, at least the triage nurse can say, okay, how much, we'll go from there, and then she can suggest how much to go up. So it's definitely not an addiction thing, it's just that sometimes things progress and we need to adjust.
So the last part here is talking about oxygen handling. We also often have patients and families who have been on oxygen and they're wondering at this state of their death process, do we need to continue wearing this oxygen? Ultimately, it's the family's decision, but some of the points of education, what are some of the things that you usually tell families?
So with oxygen, if very often we have the patients where they're really off, they don't want it, it's not comfortable. At some point they just want things off. And if they are okay in terms of they do not look like they're struggling to breathe, I tell people leave it off. And it is scary because then their oxygen saturation drops, 80s, 70s. That's okay. It's okay as long as they're comfortable. Reason why the end of life, why it doesn't matter too much is because they are not circulating oxygen in their blood like we do. We're basically blowing air at them. I will say though is that I have this talk with people, but I do point out that it is up to you if you want to remove it. I never want someone to feel like mom passed because I took their oxygen. It might not be true, but it is something that you want to know.
And, with hospice, your nurses coming in, taking vital signs daily when somebody is at this point in their life, the oxygen saturations will be low. That is probably another symptom you will see, but that is a normal part of the death process. Use of oxygen or removing the oxygen will not prolong death or speed up the death process. Having the oxygen on will not make somebody necessarily live their longer, and taking it off will not necessarily make them pass faster. But that is often a very scary conversation to have. So that is conclusion of the presentation for end-of-life medications. Are there any questions at this time? Have you ever dealt with any of those medications or heard of them before?
We're definitely using
Morphine and
morphine and lorazepam.
Is that something that scares you when you hear morphine and lorazepam? What has been your experience?
Not scared me, but just I'm still working on being comfortable administering. But I've done it a couple times, but I just need to get more hands on.
Gets easier. The first time I was a nervous wreck.
Yeah.
Now I'm just kind of nervous.
Not the wreck part, just the nervous part.
Well, it's not a medication that like Zofran or Senna that you see over the counter, right? So it's new, and anything new can be scary.
Yeah.
Definitely.
And we use something different, Miles, for drying up patients. What was the name?
Hyoscyamine can sometimes,
Yes.
Yes.
And atropine.
and atropine, yeah.
There are several different medications that can be used. This is just what we use in our comfort pack.
Yeah.
But
I
other
wasn't
hospitals,
familiar with that name, and
Yeah.
this is our little book that we read more.
other hospices, they might use different brand names, but they all essentially do the same thing.
Yeah.
And then what was the fourth one? Began with a O.
Ondansetron, also known as Zofran. That's for the nausea and
Did we
vomiting.
use that?
That wasn't on our list here, but
What do you have on your list?
we have morphine, the haloperidol.
Okay.
Delirium. That's pretty. That's it. Isocamin, Leptin,
Yes.
and then lorazepam and
Can you describe how, I might have missed it, but how morphine works on making breathing easier?
So it helps relax your diaphragm. And it, you know, and if that person is agitated and that's why they're breathing so fast, then it helps calm. But really that's what it is. It's what relaxes the diaphragm. So like for example with the breathing, we call it chain Stokes breathing. And like we have pointed out, it can be just really deep and all of a sudden very shallow, or they stop breathing. As long as they're not breathing at a rate that you would get comfortable with. So I always tell people, look how they're breathing. Is it like this? That's not comfortable. But if it's just very like deep all of a sudden and very shallow, that's okay. The morphine is going to help just relax and not take away the erratic breathing. And that's what we want. That's normal, the way they're going to breathe. We just want to relax them so that they're not breathing at a fast rate.
Do you ever have families that come in and are nervous about these medications at all?
I haven't experienced that, yeah. Laurel, do you know? They were asking if there's families that are, I'm sorry, what was that?
They're ever like nervous about some of these different meds, you know?
Some of the families, do we ever have that?
Yeah, it's pretty common, I would say.
And
Yeah.
they have said that they're uncomfortable with morphine, with their family member getting morphine, then
Right.
kind of talk them down.
Then we just educate and
Yeah.
talk about it.
Educate.
Sometimes we'll involve, of course, their hospice team.
And those are things with morphine, the biggest myths is people believe that, you know, this will kill my loved one, or I'm going to speed up their death, or I'm going to overdose them, something like that. Valid, very valid fears, very valid reasons to feel nervous about it. However, you know, that is not what morphine does, that's not our goal. And you can remind them that, you know, every person here is on a hospice, correct? So, you know, there's a physician monitoring each dose. So it's very carefully watched.
This is something I'm curious about because I'm so passionate about hospice. I'm raising my voice to make sure it gets to there too. So because I believe in hospice and palliative care and investing in research in it, do you know of experiments or further advances or progress in pain management or symptom management, in pharmacology, in medications, you know, trying out new things, or basically that. Are there new medication research projects going on regarding care of those symptoms?
As far as medications, I don't know. I can tell you that, say, and you may see this, if a patient is allergic to morphine or they're not responding, then we switch over to hydromorphine. So always know that if something isn't working, then there always is another option. But I don't know if there's further advances or anything else that we're trying.
I don't know either. I mean, we use what works for our patients, you know. Like she said, if morphine, some people do have not a great reaction to that or are allergic, so there are other options. Hydromorphine, Dilaudid, it's another word for that. Now, these are that's why, you know, I trust this you on your team. I mean, Yala is a nurse, so she can describe medications, you know, more qualified than I am too. I'm a social worker, so we have a different approach to things. We have our chaplains have a different approach to things, and without all of us as a team, you know, we wouldn't be able to provide the care that we can. So we all, you know, it comes from different directions. It's not just medications. There's so many other things that we work on. There's every bottle.
What's the difference between morphine and hydromorphone?
It's just a different medication. Both are narcotics. It's just that some people have that allergy, you know, and vice versa. Maybe they have an allergy to hydromorphone, and we absolutely need to know that because what if the morphine's not working? That sort of thing. But yeah, we do it if there's an allergy or they're just not achieving any kind of pain control.
The morphine I've seen here has been mostly hydromorphone with pretty well.
So that's, yeah, hydromorphone is Dilaudid. So that's not morphine. So hydromorphone and morphine are two different
Okay,
things.
okay.
It's Roxanol too.
Roxanol?
Roxanol,
That's
Roxanol, that's.
I don't know why they make them all so hard.
I know.
So,
And all the different names.
Yeah, exactly.
Very,
Yeah.
Do you feel more comfortable just hearing these things, like the facts and the myths? Does that provide you more comfort so that you can educate your patients and their families and make them feel more at ease?
Well, it's good to know, like you're saying, all those myths, that's a lot of myths for morphine.
Yeah.
And I can see how families would be.
there's a lot of reasons why it can be scary. You know, the myth about, well, my family member get addicted to this. They might have some trauma of their own, you know, or a history of addiction in the family. So that is a very real thing for people to be scared of.
Yeah, and we hear a lot, I was talking to you before this about, I hear often, well, my grandma passed as soon as they put her on morphine. I even had a caregiver actually just a couple of days ago tell me that in the facility, oh, he passed as soon as they put him on morphine. And that's where it's good to provide that education. That is not the reason why. You know, we extend their life with comfort versus, you know, hastening death. So I think it's very important to know these facts, become comfortable with it, and ask questions so that we can spread the word that that's not it.
I think definitely if people truly believe in these myths that we presented, that could accompany them with a lot of guilt. And so providing the facts, spreading that education can assist with some of those difficult emotions experienced during this time.
So for some reason I'm thinking that I've seen hydromorphone more commonly here than morphine.
Not more commonly, but we have had hydromorphone.
Oh, okay. Okay.
The morphine is nice because it's a liquid.
Yes.
I don't think hydromorphone comes in a liquid form, at least I'm not.
It does.
Maybe it does, okay.
It's a little harder to find, but
Yeah, I was about to say, it's hard to find.
But yeah, having that liquid makes it nice when you are giving another medication with it. Instead of adding water, you can just use medication with medication.
Exactly. Crush it.
Yeah, just squirt it into the cheek.
And now with most tablets, it can be put in the cheek or under the tongue as well and dissolved. They don't always have to be crushed.
They can, but honestly, when we're at that point, we are giving both, right? So I tell people just crush it, mix it, give it together. It's going to work so much better together anyway because they do two different things, but synergistically work together really well.
And specifically, that's lorazepam and morphine you're talking about working in that synergy.
Either that or if you're doing the hydromorphone and then with lorazepam.
That's great. What about disposing?
Great question.
Just in case there's people watching who are interested.
Great question.
Yeah, so I know for us, we never take them. It'll be up to the facility. Sometimes I know the pharmacy comes in, I don't know what they use. But So yeah, if it's a facility, usually like the other narcotics, they'll take it away by a pharmacy, or we can destroy with them, if that's allowed. Or if it's at home, then we will destroy with the family.
What would be maybe your message to healthcare providers who are, let's say, inpatient, or where, like me as a nurse in my background, it's always this extreme caution and fear and last resort, and maybe even for medical doctors as well, who are taught, there's a big opioid crisis and we don't want to be prescribing these. So what would you say for that, and how would you maybe clarify the difference of hospice?
I think the goals of care are different. The goal with hospice is comfort and pain free, whereas the goal, if you were going into the ER, for example, if you're going for some type of treatment, it's getting better. So that is where the big difference lies here.
Yes, and it's a shift in mindset too, and also, coming from the hospital and going into hospice, I had a hard time with that because we don't use narcotics so freely in the hospital. But then again, we have that knowledge, we have that background, medical providers, right? But when you go into hospice, then you have to shift your thinking to, well, what does morphine do to the body for this particular patient? How's it going to help? Versus maybe you're going to use morphine, say if someone has some sort of hip replacement or something, then different goal, probably different dosing, and time frame that they're going to be on it.
Great point. Now I know, sadly, some people are still dying in hospitals instead of in a home or a home setting. So if there are nurses who maybe are watching this, or doctors, would you recommend adding these medications and maybe looking at things different if they notice that that person is starting to decline, to start to adjust to a more palliative or hospice mindset?
And see, that can be difficult depending on your provider that you're working with too. Thinking back during COVID, we had a lot of comfort care patients, and it was a different kind, and don't ask me, it was so long ago, but I know Robital was one for the secretions. I do remember lorazepam, IV lorazepam, and I don't recall if we used morphine or not, but very small amounts and not so frequently. So it's still a very different experience. And sure, you have that IV that they're going to receive it quickly, but again, very different mindset whenever you're in a hospital, because even if you know the comfort care, you are in that safe mode. So the nurse should be an advocate. They should be saying, hey, Dr. So-and-so, I know we did this, but the patient is breathing rapidly, they're restless, can we increase this dose? So advocate for your patient.
And I think the patient and the family have to be ready for hospice. They have to be ready for lifetime. It could be one thing, me thinking that somebody is eligible for hospice and they could benefit. It doesn't matter if they don't want it themselves. It's their own journey. So if they're ready to have those conversations and accept that education, then I believe that would be the most appropriate time to start palliative conversations and a different direction in both of care. So yes and no, I guess. It just depends on the person and the patient if they're ready. You never want to push somebody to do something that doesn't align with their own goal of care.
Questions from you?
Well, the wasting of the meds, like you were talking about with charcoal, whatever, is a little bit confusing to me, because before I started working here, I thought that what had to happen with meds that are done, that aren't going to be used anymore, is they get incinerated. And is that what they usually do with the meds, like when you turn them into a Walgreens in that little place where you're turning in excess meds?
I don't know.
I don't know what they do there. Yeah,
Yeah, because pills, and I tell patients that sometimes, or
wasted, it's okay to put it into the landfill. Not down the drain, but in the landfill.
You know, I don't know again on that part.
I mean, I think that's what you said.
Well, you said after you put it like in kitty litter or whatever,
Oh, okay.
then you put it in the trash.
In a bag, like it's a closed-in sealed
Yeah.
bag, yes.
Yes.
And then it goes to landfill.
Yes.
But is that only for control substance or operating med?
Control, I mean, you could do with every medication, but whenever a patient has so many,
Yeah.
that's when I always suggest just take it to a drug take back program. It's so much easier to dispose of that way if you have so many of those.
Yeah,
And
yeah.
even when somebody discharges from hospice, some people just, they don't meet criteria anymore and they in fact get better with all the support that does
Right.
happen. People ask, what do we do with those medications? They are technically the patients. They're in their name and they do theirs.
Yeah.
But the only thing that like dish soap or kitty litter or coffee grounds does is it makes that medication undesirable to ingest. And that's really why we just
It doesn't like do some magic.
It's just
nothing magical.
like you're thinking that maybe somebody might get it out of the trash and use
So
it.
yeah, it's not like that.
Yeah,
But
I
just
know.
be very
Yeah.
cautious, if you're in a home with kids or,
Yeah.
you know, if they're here and, or they're pets, just making sure that when you dispose of it, make people throw it in the trash right away.
I know here that the medication is kept in, a locked area. We provide care to a lot of patients in their own homes, just for your knowledge. And if there are ever, young children in the home or any possible issues, we provide lock boxes and combinations and things like that. So.
I got one more question.
Oh, yeah.
Do we have any drug-seeking people here? People that have just wanted to get high from the morphine?
No, we've never had, whether it's family or volunteer or anybody who's come to the home, or anyone from the outside just kind of lurking around, or
Patients that want more, that want to get high?
no,
No.
I've never seen that.
Okay, good.
I've been working with Miles, my understanding is that, our patients that do come here are in that transitioning process and their death process, to a point where, for me, if somebody at that point is asking for something, it's because they need it.
And they're gonna have that tolerance, right? So if they were addicted to a substance, they're probably gonna need more, which are important things, that we do. And same goal. We want them to be comfortable no matter what. We're not gonna-
Yeah, and you've had, a report that says pain level is what the patient says it is. Great, well, thank you. Very helpful.
Thank you, Amber Care. Thank you both for being here.